Mr.
Well, hi, everyone. We're pleased today to have joining us Dr. Winifred.
David, your mic's muted.
Sorry, folks. So today we're honored to have with us Dr. Winifred Quinn, who's on my screen right beside me, who is with the AARP, a large nonprofit, nonpartisan organization in the United States that helps enable independent aging so that people age by their own choices, not by things that are forced upon them. Dr. Quinn has multiple expertises, received her PhD from Rutgers University, and will share our panelists' backgrounds and information with us today. Thank you, Dr. Quinn.
Great, thank you so much. And hello, good afternoon, good evening, good night to folks around the world. Thank you so much for joining us. And mine and Peter's colleague, Lynn Mertz, is helping us today. So I'm going to ask if Lynn can bring up our slide deck presentation. Great, thank you so much. So, so with us today, great, thank you, Lynn. With us today are, rather than Dr. Wipada from Thailand, from Chiang Mai University, who was going to join us, we have in her stead Dr. Sivarat, who just participated in the prior conversation. So thank you so much for joining us today, Dr. Sivarat. And we also have Peter Rundlet, who is the Vice President of International Affairs and PRI's International Affairs with AARP. If you could go to the next slide. Great. So thank you, Lynn. So actually, before I get started, what the lineup will be today is I will share with you background on the Center to Champion Nursing in America and our Future of Nursing Campaign for Action. And then we will move on to Peter Rundlet, who will talk about AARP's international work and our AARP's work in longevity and how COVID is impacting that. And then we will hear from Dr. Sivarat, who can talk about the preparation and deployment of nurses in Thailand overall, and then if and how COVID is affecting the education and or deployment of nurses, especially as they take care of older adults. So, so with that, I will go ahead with my part of the presentation. So normally in the United States, healthcare is paid for by the insurance we have. Most of us who are insured get it from our employers. Older adults get it from a federal social program called Medicare. And then people, younger people who, younger adults and children who are impoverished tend to get it from Medicaid, which is a social insurance that is both, it's a combination of our federal government and the state government. And we like to talk about a healthcare system in the United States, but there's not much of a system. It's more of a variety of systems. And because there is a variety of coverage and a variety of systems, healthcare is not the most rational of businesses that is managed. And so we spend quite a bit of money, and for a industrialized society, we don't get much of a return on the investment, not as much as other industrialized nations obtain from their investment on healthcare. And so, and we have, as is the truth for all nations, an aging population. And even before COVID, our population was getting sicker. Which is a result of the inequities around the social determinants of health. So the many impoverished people struggle to find affordable, quality housing and transportation. They are often at risk because of poor quality air and water, and the lack of access to affordable, fresh foods. So, so all of those factors lead to a lot of challenges. And Lynn, if you could move to the next slide, please. And so there are many in the United States over the last 10 or more years that have been looking at the value that nursing brings to address all of that. Why is it important for us to have a highly educated nursing workforce to address the poor quality of health outcomes and the social needs that people have that affect those outcomes? How can nurses be involved in that? And so a few different organizations that have been involved in nursing policy over the last 10 to 15 years are AARP, the nation's largest consumer organization at 38 million members. The AARP Foundation, which is a branch of AARP, it's our philanthropic arm, is very concerned about social isolation among older adults and food security for older adults. And then the Robert Wood Johnson Foundation, which is the United States' largest healthcare philanthropy outside of government. And so the Robert Wood Johnson Foundation started about 55 years ago, and it was created through some of the funding from the corporation Johnson & Johnson, which most of you, if not all of you, have probably heard of. It is based in New Jersey. And so 10 years ago, the Robert Wood Johnson Foundation partnered with what was the Institute of Medicine and is now the National Academy of Medicine to generate a report on what nursing in the United States would need to do to pay attention to ensure that it was an effective 21st century workforce in the United States, addressing all of the problems, all of the challenges that I mentioned in the first slide. So they generated a report with numerous sets of recommendations, and then they provided an update on that report 5 years later. The Robert Wood Johnson Foundation asked an entity that was already funding at AARP, called the Center to Champion Nursing in America, to apply for a grant where we could be the operational arm to implement the recommendations out of the Institute of Medicine. And so we have had that grant for 10 years, and we created state-based coalitions. Our esteemed dean from Emory University, Linda McCauley, is one of the co-leads of the Georgia Action Coalition. And we have action coalitions in nearly every state and in DC. So, and these state-based action coalitions have been implementing the recommendations over the last 10 years. If you could go to the next slide, Lynn. So one of the recommendations is about advanced practice nurses, such as nurse practitioners, which is the most prevalent of the advanced practice nurses in the United States, to practice to the full extent of their education and training. And so in the United States, which is probably quite different than in the Asia countries that are joining us today, healthcare policies, and this is another challenge in terms of the healthcare system. Healthcare policies are typically regulated at the state level, including scope of practice laws that determine how much care a clinician can provide or an advanced practice nurse can provide with, without contracting with physicians, and also with contracting with physicians. And so the Institute of Medicine 10 years ago, their first recommendation was that all states, and where relevant, the federal government, should modernize their scope of practice laws. So we as advocates through AARP, we work on that. That is one of our big issue areas. If you could go to the next slide, Lynn. And so during COVID, we especially made this case that for the states that have not made any changes to their state scope of practice laws, we highly encourage them to ensure that all clinicians were serving people in need, which of course now is nearly, there have been 13 million people in the United States alone who have been diagnosed with COVID. But it's also to help their family caregivers, support them. And so here's a screenshot, thank you, Lynn, of taking care of that screenshot of a paper that I co-authored with a nurse leader that is one of our advisors, along with two of our nurses who were either working with us at the time or are still working with us, and another CCNA colleague, Claudio Gualtieri. And we talk about the federal and state laws that changed regarding the federal and state laws regarding advanced practice nurses, and some registered nursing policies that changed to reflect the needs of COVID-related issues. If you could go to the next slide, Lynn. And a very important bit of research now coming out of AARP. It just initiated, it just came out publicly in October and was updated in November, and will continue to be updated on a monthly basis. And that is the Public Policy Institute's COVID nursing home dashboard. And so this is led by our boss, Dr. Susan Reinhardt. She is a nurse. By the way, I am not a nurse. I work on policy issues as they intersect with what people need and what nurses can do. Susan Reinhardt is a nurse. She is the Senior Vice President and Director of AARP's think tank, the Public Policy Institute, and is also the Chief Strategist to all of our nursing work. And so we, for the last 10 years, the Public Policy Institute has been putting out, we have its 4th iteration of a long-term care and support services scorecard. We came out with the most updated one this summer. The data it reflected was from 2019 and was absent anything about COVID. And so numerous teams within AARP asked the Public Policy Institute to have a companion dashboard focused just on COVID, because we know that, unfortunately, in the United States, at least 41% of the COVID-related deaths are people living in nursing homes and people working in nursing homes. So we really need to be paying attention. I mean, we knew this anyway in the United States. We've been needing to pay attention to the quality of care or lack of quality of care in our nation's nursing homes. And very tragically, the COVID pandemic has laid bare how the problems in long-term care in nursing home facilities. So the nursing home dashboard can help those of us in the United States look at what our dashboard measures in each state looks like. So I believe that's it for me. And at this point, I'm happy to turn it over to Peter. Is that correct, Lynn? Yes, there we go. Thank you, Lynn, and thank you, Peter.
Thank you, Wynn, and good morning, good afternoon, and good evening to everyone around the world. I'm really pleased to join you. given the focus of this conference and of my colleagues, I am a little bit of a sideshow for this panel because I'm going to be talking a little bit about the global megatrend of healthy longevity and some statistics related to the impact of COVID on older populations around the world, as well as tell you a little bit about the role of AARP's team, international team, and what we do internationally, which is the team that I lead. As many of you may know, and as Wynn just said, AARP is a US nonprofit organization with nearly 38 million members dedicated to empowering Americans 50 and older to choose how they live as they age. But most of the organization, there's I think something like 2,500 employees. Most of the organization is focused on the United States for understandable reasons. But we are also very engaged internationally. I lead a small team that's focused on issues that face aging populations around the world. And I'll talk to you a little bit about that in a moment. But first I want to talk to you about how we are all witnessing a seismic demographic shift in the world. All societies in the world are in the midst of what the UN Population Agency has called the longevity revolution. And by this, I mean that population aging is a global phenomenon. Virtually every country in the world is experiencing growth in both the size and the proportion of older persons in their population. So we're seeing increasing numbers of older people, but also an increased percentage of the population are tending to be older as we move forward. And as you'll hear, Asia's leading the way in this. Demographers predict that in countries that are aging well, in fact, more than half of the children born today will live to see 100 years old. So it's at the end of the day, it's really a human success story, this population aging, because it gives us a reason to celebrate the triumph of public health, medical advancements, economic and social development, over diseases, injuries, and early deaths that have limited human lifespans throughout our history. So now I'll turn to some of these statistics on aging. We're seeing in these global trends kind of across the world for the first time in history, starting in 2018, people aged 65 and older outnumbered children under the age of 5. So we start to see that shift. Last year, and a lot of these statistics, of course, are taken from the UN population statistics, and they did a big report at the end of last year. So the baseline for many of my numbers, it starts in 2019. So last year, only 1 in 11 people globally were over the age of 65. But by 2050, that number will grow to be 1 in 6 people, or nearly 16% of the population. There were 703 million people aged 65 or older in the world last year, but that number is projected to double to 1.5 billion by 2050. And maybe even perhaps more interestingly, the number of people aged 80 years or older is projected to triple from 143 million in 2019 to 426 million in 2050. So I'm going to continue with the statistics, but it's just to say that this is really a megatrend where people talk about artificial intelligence and automation, something that many policymakers haven't quite really focused on to the extent we think is needed, is the aging population. And again, this is a trend that's taking place in the United States and around the world. Today, Japan is the only country in the world where those aged 60 and older represent 30% or more of the population. But by 2050, 62 countries, including China, will reach that milestone. So you can see the significance of this. In Asia right now, well, by 2050, 1 in 4 Asians will be over age 60. And Japan and Singapore, depends on what numbers you look at, but they're kind of neck and neck for having the longest life expectancies in the world at about 84 years right now. The US is also aging. By 2034, the number of adults 65 and older will exceed the number of children. And literally every day in the US, more than 10,000 people turn 65. Now, one of the things that we're doing really across the enterprise, but on the global thought leadership team as well, is focusing on the kind of equity implications of longevity, because we know that people aren't aging equally. These longevity gains aren't distributed equally across the population. The inequity that you see in health and social economic status, and that Wynn was talking about, when that happens early, it compounds over time, and it leaves certain populations behind and not living quite as long. There's an interesting gender aspect to this, because the majority of people living past 80 are women. In both developed and developing countries, women outlast men by nearly 5 years. And this has big implications related to poverty, because women over age 65 have on average 27% lower pension or Social Security than men because of lost wages throughout their career. And so they're much more likely to fall into poverty, which is clearly a big concern. Turning to the slide now on COVID-19 and aging. I think Quinn just mentioned that some stats about long-term care facilities, which I'll get to. But really around the world, approximately 75% of COVID deaths have been people who are 65 and older. And so we're seeing lots of implications about that with the sort of proportioning of an allocation of medical care to certain populations and some issues with respect to rights and how people are being treated. In the US, 80% of deaths have been of people 65 and older. And I saw some earlier, I called in to the conference a little earlier and saw some of these statistics, and again, they're changing day to day, but according to IHME, there are about 58 million cases, a little more than 58 million cases of COVID worldwide, and there have been more than 1.4 million deaths already. At present, it's estimated that about 5% of the world's population has been infected already, but they project that this will go to 10% by the very beginning of March of 2021. Sadly, but predictably, perhaps predictably, the virus disproportionately impacts lower income, vulnerable people who have less capacity to cover, and so we're seeing a disparate impact there. And for those of you who have been following the statistics in the United States, there's been a wildly disparate impact on communities of color. Blacks, Latinos, and indigenous populations have been hospitalized and they're dying at much higher rates than white people are. Finally, on the statistical front, I'm taking a look at COVID-19 and long-term care facilities. About something like more than half of COVID deaths in many countries have taken place in elder care homes and long-term care facilities. In Canada, for example, 81% of deaths have been in nursing homes, whereas I think Win just mentioned that in the US, about 41% of all deaths have occurred in long-term care facilities, which is something AARP is watching very closely. And I think just this past week that we surpassed 100,000 deaths in long-term care facilities. In addition to that, it's estimated that about half of all the US nursing homes have staff infected by COVID-19, which is a statement about how we need to protect our caregivers as well. So something we should focus on. So sorry for that quick run through the statistics. I wanted to tell you a little bit now about the role of the international team at AARP, since many of you may not have been familiar with it. Our motto at AARP is that we constantly strive to be a wise friend and fierce defender of the 50+ population. But our founder from early on, Ethel Percy Andrews, also made clear that what we do for one, we do for all, which has real implications about our work internationally. So although we were founded in 1958, from as early as the 1960s, AARP has been working internationally. All of our international efforts are really based on the premise that we can learn a lot from the experiences of other countries, and that perhaps they can learn from our experiences too. So it's really based on an exchange model, looking to make partnerships and share information about innovations that are taking place. We know that if we're to succeed in our mission to build a society for all ages, where everyone has the opportunity to age with dignity and purpose, we need to reach beyond our borders to engage leaders in other countries and from all sectors, private sector, public sector, nonprofit sector, to help find solutions to our policy challenges. So key focus in this bullet here is as we identify and share innovations from around the world and support groundbreaking research related to global aging. And I'll talk to you about some of those things and how we're doing that in just a second. I think it's important to mention, as I'm talking at the end of this, I'll get to our contact information, because given what all of you are doing around the world, it's really helpful for us to be in touch with you and to be aware of the things that you're doing, because we have different ways of promoting that learning, and certainly we can benefit from it in the United States. So I'll quickly run through some of the kind of notable projects and key things we do internationally. Perhaps most notable is our interaction with our engagement with the UN at really high levels. Since 1985, AARP has had a full-time staff person working up in New York, really with the purpose of engaging the UN, really pushing that international body to carry our message forward about how to think about and care for older adults. And we've had consultative status, official consultative status by the UN Commission for Social and Economic Affairs since 1985. And this is really, this presence there and the effort there has really borne some good fruit because, for instance, in 2015, as the United Nations was taking up the global goals, the 17 Sustainable Development Goals, we advocated strongly together with other organizations that older persons need to be considered in each of these. And we were able to get language in 15 of the 17 Sustainable Development Goals that addressed in some way or another the older people and the need to take care of them. This year, as we were watching COVID had this deplorable impact on older people, we started engaging in advocacy with the UN, first with the UN High Commissioner for Human Rights in Geneva, and then directly to the UN Secretary General. And we were very grateful that in May, the UN Secretary General issued a policy guidance on the impact of COVID on older persons, specifically focused on older persons. After that, we were able to set up a 45-minute interview with our CEO, Joanne Jenkins, and the UN Secretary General to publicize the findings and recommendations around the world. The interview was seen all over the world, and we were quite pleased with that engagement at that high level. In addition to the UN, we work with other international organizations and have significant partnerships. For the last couple of years, we've had a very strong partnership with the World Economic Forum and the Organization for Economic Cooperation and Development, the OECD. And we're working together on a project called Living, Learning, and Earning Longer. It's a collaborative initiative intended to engage the private sector. We have 50 global corporations who are working with us to really come up with a set of policies to help promote the multi-generational workforce. Because as people live longer and healthier lives, they will either need or want to work longer. And so the workplace needs to figure out how it can best accommodate that and take advantage of older workers. In addition to that, we have a partnership with the National Academy of Medicine on something called the Global Roadmap for Healthy Longevity. And this is intended, we had this year intended to be in Japan and Singapore and some other places to develop evidence-based recommendations to increase the healthy lifespan. That work will continue into this year, and we're engaging virtually to produce a big report at the end of the year. We work closely with the World Health Organization. Some of you may have heard that they have recently launched something called the Decade of Healthy Aging, which is from 2020 to 2030. And the UN General Assembly is taking that up. So it's going to be not just a program of the World Health Organization, but of the broader United Nations. And our team is focused particularly deeply on a couple of things. One, we're working to support the global campaign to combat ageism, which is designed to help fight and support the rights of older persons, especially in long-term care facilities. And we're also doing some work to help local communities around the world support their aging populations through something called the Network of Age-Friendly Communities. And I'll talk a little bit more about that in a second. Another thing the international team does, and I'm hoping some of you have seen this, is publish something they call Aarp the Journal. And every year for the past 13 years, we've published this periodical that has insights and learnings from all over the world. But each edition also has a deep dive into the innovations of one country. This year, we just released last month, we did a deep dive into Singapore. And I wish I could hold it up, but you can see a picture of the cover there. If you go to our website, which I'll give you the address at the end, it's really worth taking a look at this. We focused on Singapore this year. Last year, we did a deep dive into the Netherlands. Before that, we did a deep dive into Japan. All of these periodicals really focus quite deeply on the innovations that take place around the world and have the greatest thought leaders from around the world contributing. As we look forward to 2021, just for your information, we will be doing a regional focus on Latin America. So this is one of the things that the team produces, and it's won some awards, which we're quite proud of. Over the years, in fact, over the decades, recognizing that we're a small team based in the United States, we've really worked to spark some other international global networks that focus on aging. And in 1973, AARP helped found the International Federation on Aging, which is now headquartered in Canada, but has over 50 organizations from around the world that engage in it on a really routine basis. All of the issues related to health, wealth, and well-being of older adults. More recently, in 2011, we helped create something called the Global Alliance for the Rights of Older Persons. And this alliance has, at present, 340 members from around the world, and they're exclusively focused on promoting the legal rights of older persons, with a primary focus on a UN convention, but they're working on rights nationally, locally, and regionally. So again, something we've been able to do is help support these larger global networks get off the ground. Finally, it's worth mentioning some of the groundbreaking research we do. For the last couple of years, we've had this big initiative called the Aging Readiness and Competitiveness Initiative, our ARC initiative. And we've had two rounds of this landmark study, which has up until now analyzed the preparedness of 22 other nations. Each one of these is a significant research report. We've worked with both Foreign Policy Magazine and the Economist Intelligence Unit to produce these deep reports about how these various countries are addressing their issues related to aging. And of course, health is a big issue when it comes to that. But more recently, someone on our team produced something called the Longevity Economy Report, which really looks at the economic contributions of the 50+ population. We found when you account for their work and spending and volunteer activity, the 50+ population contributed $8.3 trillion in the United States alone to the economy here in the United States. And it's projected that figure will triple by 2050. We are currently starting to look into research around the world looking at similar economic impacts. It's also worth mentioning, this year and moving forward, we talked about the network of organizations that are focused on the rights of older persons. We are also directly doing some of that work. Our Chief Public Policy Officer, Deborah Whitman, recently sat down for a fireside chat with the UN High Commissioner for Human Rights, former President Michelle Bachelet from Chile, to talk about the importance of older persons' rights, particularly under COVID. And we're working with Human Rights Watch, among others, to really look into areas of abuse that need to be ameliorated. Lastly on my list, I just want to mention we are doing some significant work related to age-friendly design in communities with a particular angle of equity. We're in the middle of a 6-part series called Equity by Design, which is really intended to promote the application of an age-friendly network that addresses disparities in the built environment. And we're working with a variety of other organizations to create the adoption of a universal age-friendly standard that should be hopefully adopted by the International Organization of Standardization. So in some of these ways, we're really trying to extend our reach through other networks and working with thought leaders and leaders of all sorts around the world. And this is why it's really important for us to learn from you, to partner with you. I hope very much that you'll reach out to us. Go to our website, which is aarpinternational.org. We would really love to hear from you and better understand what we need to know and to elevate your voices, because we have a good platform. Now, I think by now you probably learned more about AARP's international work than you cared to. But as Wynn will describe, AARP has been a true champion of nurses and nursing to help address all people's needs. And we're especially focused on the importance of nursing to help people's needs during COVID. And so I want to turn it back to Dr. Quinn so she can tell you more about our efforts in that regard. Thanks.
Great. Thank you so much, Peter. Thank you. It's so great to learn more, even more about what you're doing. And thank you for your leadership in that, in our efforts in the international stage. And again, I do hope that nurses, whether you are in the United States or internationally based, if you reached out to Peter to learn more about AARP International and to inform AARP International about the status of nursing in your nation, and if you think that this would be something you would want AARP to converse with you about, it would be really great. So at this point, I'm happy to actually, Lynn, can you go to the next slide, please? I'm happy to introduce our guest speaker, Dr. Siri Rat, who is replacing Wipada, Dr. Wipada, who was on the prior conversation but needed to hang up because she was traveling in Thailand and needed to, quote unquote, hit the road, as we would say in the United States. So with that, Dr. Surat, if you could share with us the status of nursing, especially advanced practice nursing in Thailand, and how nurses and advanced practice nurses care for older adults. What does that care look like? And what is the preparation of nurses to help people with older adults, the education? Oh, and you need to unmute your phone, your microphone. We still can't hear you. David or Steve, can you help Dr. Surat unmute her microphone?
Okay, sorry. Could you please stop the share screen? And then I'm going to, okay, thank you very much. Okay, thank you very much, Dr. Quinn. So let me share our PowerPoint, my PowerPoint. So I may have allowed 10 minutes
Yes,
only,
please.
right? Okay, so I would like to share with you the overview of the levels of nursing education in Thailand, very brief. So the first program of undergraduate degree nursing education start in 1956 at the School of Nursing and Midwifery Surirat Hospitals of Mahidol Universities in Bangkok. You may know about this university. But in 1960s, a 3-year program, we start nursing in 3-year programs. A diploma in nursing was introduced. And also at that time, the midwifery certifications still require a further 6 months training. So it means that 4.5 years for nursing and midwifery. And also at that time, we have a 1-year practical nurse, we call PN programs, was also initiated. But in Chiang Mai universities, I work in the Faculty of Nursing, Chiang Mai universities. We have the 4 years Bachelor of Science in Nursing in 1966. And in 2003, we have a 4 years International Bachelor of Nursing Science programs was launched in 2003. And the Faculty of Nursing Chiang Mai University is the 3rd nursing faculty in Thailand, but it's the first regional nursing faculties in Thailand in 1972. For the Bachelor of Nursing, prepare nurses, the core competencies of the undergraduate prepare nurses, according to the Nursing Council of Thailand, the core competency including like direct care. So why I bring the core competency up? Because I would like to compare between advanced practice nurse and also the undergraduate nurses. The core competency is quite similar, but what are the difference between the RN and the APN? The second is the leadership, management, and quality improvements, scholarship and research for the undergraduate students, and also the competencies of communication, relationship, information and technologies, and ethics. And the last competency is social competency. But for the Master of Nursing, the first master level programs in nursing, we start with, in the first program is the nursing administrations, was developed at Chulalongkorn University in 1973. But the Faculty of Nursing Chiang Mai Universities, we start the master program in medical and surgical nursing in 1986. And the Master of Infection Control Nursing, the program started in 1992, and it's only one master programs of infection control nursing in Thailand. So if you would like to continue master program in infection control nurse, you have to come to Chiang Mai University only. And in 1996, the master program in gerontological nursing is started in Chiang Mai University, Faculty of Nursing. It's the first program of master in gerontological nursing, because at that time we have the faculty members that earn a doctorate program, a degree from university in the US. For example, me, myself, I got the scholarship from the government for the PhD in nursing from University of Washington at Seattle, long time ago. So we start we start a program of elderly care or elderly nursing at that times. And I think that I'm so lucky to have a specialty in gerontology, because right now in Thailand, we are going to move to the age societies. Right now, the proportion of people age 60s and above in Thailand is nearly 20%. And in the near future, I think that we are going to move to the super age society very quick. And for the advanced practice nursing program, master programs, the APN emerged as a result of the need to contain costs, improve access to care, serve the underprivileged group, and respond to the complicated health needs of populations that the chronic disease. And APN was approved in 2003 by the Thailand Nursing and Midwifery Council of Thailand. And the certification process for APNs has taken place yearly, with approximately 10% of Thai nurses decided as being engaged in APN. So right now, all over Thailand, we have about 1,000 and almost 500 APN all over Thailand. And 9 specialty areas of APN, like maternal and newborn nursing, pediatric nursing, adult and elderly nursing, and also gerontological nurse practitioner. So we started GNP 2 years ago. Previously is the gerontological nursing, not specific to nurse practitioner. Mental health, psychiatric nursing, community nurse practitioners, midwifery nursing, infection control nursing, and anesthesia nursing. Only anesthesia nursing that is not master prepared, but is APN, because the association of, the doctor, the physician not allows nurse to have master prepare for anesthesia nursing. They have like 1 year training. So we have 9 specialty areas of APN, including the GNP. APN are required to perform professional activities within the 6 laws according to Nursing Council of Thailand. So 6 laws of APN is some law is similar to the undergraduate prepare, but some laws are different. For example, evidence-based practice. We start evidence-based practice laws of APN, but right now for the RN or GN, they adopt the concept of evidence-based practice for the routine nursing care as well. And also the laws of consultation, consultant collaborations, coach, preceptor, educators, change agent, and the most important is the care management. In Thailand, the care managers of the long-term care or the palliative care is the responsibilities of the APN. Yeah, it's not the social workers. In Thailand, we don't have that many social workers, so the managers of the long-term care and palliative care is the APN. For the doctoral degree, the first doctoral degree in nursing, established in 1990 as a collaborative program between the 4 major universities, including Chiang Mai University. And currently, the doctoral program in nursing are offered by 6 public universities, including Chiang Mai University. So what Masters of Science in Nursing prepare nurses do before COVID-19 and during COVID-19. As I already mentioned about the core competency of the APN, so the GNP, the same core competency as I already mentioned, but the difference in this specialty area is the target population. So the GNP, the target population including healthy elderly, chronically ill elderly. This is the most important because about, I think that more than 50% of elderly, Thai elderly, they have multi-morbidity, more than 2 chronic diseases, especially the physical only pattern like hypertension or diabetes or COPD, something like that. And also the GNP care for the dependent elderly. I mean, or the people that the ADL scores below 12 out of 20 is like partially dependent and the totally dependent elderly. Even though it's only allowed 10% of Thai elderly that they belong to the totally dependent elderly. And also the frail elderly and end-of-life elderly. The end-of-life elderly group is quite different from end-of-life patients in other age group because it's most of the end-of-life patient is the cancer. But for the older people in Thailand, the end-of-life is not cancer. It's the chronically ill. So the different. So most of the palliative care nurses, they have been trained to care for the cancer patient end of life with the cancer. But palliative care nurse, most of them, they're not be good on care of end of life with the multi-morbidity like the older people. And the settings, what the GNP in Thailand works, they can work in communities, care of older people at home, because most of the older people in Thailand different from the US and the Canada. Most of the Canadian or the US elderly live in the nursing homes, but the Thai elderly, about 80% of them live at home. The policies of the Thai government will not encourage. We prefer family members care of elderly at home. So the models of age-friendly or age-in-place, age at home is the major issue that we try to develop the age-in-place model for Thai elderly. And about 20% of Thai elderly live in the nursing homes, home for the aged, but mostly in the private organization, private nursing home. It's not a government nursing home because government nursing home is not that many.
Okay.
But once they get sick, they move to the hospital. We have 3 levels of hospital in Thailand. Health promoting hospitals, we consider as a provide primary care services at the sub-district levels, at least 1 APN per 5,000 population. The community hospitals provide secondary care at the district level, at least 1 APN per hospital. But for the tertiary hospitals, at least 1 APN per 120 inpatients.
Huh.
Yeah. That the requirements, but right now we don't have that many APN. So we cannot fulfill these requirements in the hospital. And also in the nursing home, few APN work in the nursing home in Thailand. Most of them work in the hospital.
Mm-hmm.
So in the communities and in the nursing home, we don't have enough APN. We have only RN or GN. Yeah. So services provided by GNP. In the hospital, we have the models like GNP-led model of care, but focus on the complicated or complex cases for hospitalized elderly, like COPD, because they have very high hospitalization rate. Heart failure, COPD, chronic kidney disease, something like that. And also in the hospitals, we try to, the nurses work in the hospitals, they develop and they adopt innovation to improve care. And also in the hospitals is discharge plannings for complex or complicated cases. We do very good on that. And also improve the referral system. From the hospital, some of them move to intermediate care, to long-term care or palliative care. So the referral system improvement is the responsibilities of the GNP in the hospital. And also genetic syndrome prevention and management is very high incidence of the genetic syndromes in for the people that be hospitalized in the tertiary hospitals, like falling rate, delirium, something like that. Mm-hmm. And also genetic rehabilitation. GNP work with physical therapists to provide genetic rehabilitation. It's not only stroke rehabilitation, but including the genetic rehabilitation.
Yeah.
Yeah. We a few minutes remaining for questions.
Right. Yeah. I was just, thank you, Dave. It, Dr.
Are here. So the first is for Dr. Quinn, and that question is that given your research and expertise and your exploration through AARP, and in keeping with our theme of the day, what implications are there for research? What questions have emerged for which there are presently no answers that nursing research may be able to enlighten?
So I'm really curious about some of the policies, the Thai policies that I'm wondering what what data they're based on, because I think actually any research that might have been done that are providing the data points that might be informing the policies would be really helpful for the United States to pay attention to right now in terms of quality of care for older adults. Dr. Siriat talked about policies in terms of advanced practice nurses per numbers of people in different levels of hospitalization, and also registered nurse staffing at nursing homes. So I think it would be really helpful for us to understand what research was done that provided that those policy recommendations. Because we at the United States, we really need to figure out better nursing policy and nursing and other healthcare staffing policies at places of care, especially nursing homes, as we see in COVID-19. So Dr. Siriat, I would love to get your email address because I probably want to follow up with you.
Okay, okay. So I will give you the email. So,
okay,
so
great.
we can together later. Yeah.
Okay,
great.
Maybe our final question, but the other one in queue right now is, what opportunities do any of you see for collaboration? And it could be international collaboration, or it could be interdisciplinary or intercareer, even outside the scope of only medical or health sciences professions. What sorts of collaborative opportunities do you see existing, or perhaps could AARP or other organizations help to encourage?
Well, I have maybe a couple of ideas, but I don't want to hog the microphone. So Peter or Dr. Siriat, if you have ideas that you would like to share.
Yeah, I would love to have an opportunities to work with, do a collaborative research with other organizations outside Thailand. It's really, because we used to work with the research team in Japan and in Korea and in, I think in Taiwan, we do the collaborative research project about the dementia care. So And right now we have some others collaborative research among Asian countries and also outside Thailand. So we really love if we start with some common concerns among other people in our, own countries. And if we take this opportunity to focus on the COVID-19 situation or pandemics and how it's influence on other people all over the world, including, Asian countries, because I'm not quite sure that we have much information about the impacts of COVID-19 on other people in what specific issues. And also for my master students, we try to let them expand the scope, like COVID-19 literacy and what factors and what are the consequences of literacy of COVID-19 among other people. Give you that example. Yeah.
Yeah, great. Peter?
I would just say, to follow up that, recognizing that different countries have different resources and are doing different things, we can learn from them, particularly countries that are having really successful interventions at low cost. One thing that our team did just right out of the gates is create a portion of our website intended to surface innovations from around the world. And of course, we're not the World Health Organization. We aren't in a position to validate what one country is doing is effective or work elsewhere, but really just to share auspicious and promising practices so others can learn from them. So that's kind of one simple response to what you just said. But I think really across the board, there are areas where we can learn from each other. We were talking very specifically about health interventions around COVID, but the social determinants of health is something that has long-term impacts. I saw an article this morning that said in Japan, more people died of suicide this past month than they've died of COVID over the last year. And that's really, it's related to COVID because of the stress of COVID, and the overwhelming majority of those people were women. So a lot of factors go into that statistic. And so I think together, thinking creatively and sharing information, we can figure out ways to have interventions that may make sense.
Yeah, I think there are some really creative opportunities too.
All right. Well, that enables us, let's see, wait, hold on, question here.
And before we hang up, I would like to thank a couple of people I didn't get to thank earlier or acknowledge earlier.
Well, do that and then we'll close with a question.
Okay, sounds good. So first of all, I would really love to thank Dr. Siriat for stepping in at the last minute. I've learned a lot just in the 15 minutes that you presented, and I look forward to learning more. If other people on the line would like to also inform successful, effective nursing policies for older adults, especially around COVID and older adult care, I would love to learn what you have. And thank you, my colleague, Peter Rundlet, for joining us today. This was really helpful. I think that what you're doing and your team is doing at AARP is very unique, and it helps make these bridges and these connections internationally. It's so important. And Lynn Mertz for helping us, and Dr. Unok, Dr. Im, sorry for the pronunciation, but Dr. Im, I know Linda McCauley invited us, but Dr. Im also invited us. She's on faculty at Emory. And Dr. Im is also on our Future of Nursing Campaigns for Action's Equity, Diversity, and Inclusion Steering Committee. She is the current president of the Asian Pacific Islander Nursing Association, and in that role, she advises us on equity, diversity, and inclusion. So I wanted to thank her for both of those roles. So back to you, David.
Final question we have about 2 minutes to answer is a question about existing research initiatives or suggestions about research related to caregivers in the area of dementia, particularly, which could possibly relate to COVID or post-COVID environment, either a COVID side effect or just a related mental health issue. What opportunities exist or what initiatives have already begun in that area?
So first of all, when you're the person who said caregiver, does that mean family caregiver, or does that mean sometimes caregiver also includes nursing and other clinical staff?
That's a good insight right there. So yeah,
So let's assume it's family caregivers, because or else I would have thought that people would have said nursing. So AARP is very much focused on family caregivers. There are many of us, including myself, who got involved as an employee at AARP because they haven't been family caregivers ourselves and having firsthand knowledge. And where Dr. Siriat underscored the Thai culture and expectation of families being the main caregiver to older adults in the United States, that has not really been the expectation. It's not part of our culture, but it is very much, it is what we do, and it's what many populations, subpopulations across the United States do. In fact, the African American population will say that they don't see themselves as a family caregiver, they're being a family member. The expectation is that they do take care of their older family members. And so when it intersects with dementia, also within mine and Peter's whole department at AARP, we have a brain health team, and Sarah Locke leads that, and intersects in the issues of brain health, dementia, and family caregivers. So please follow up with me, wquinn@aarp.org, to find out more.
Thank you. Thank you, Dr. Quinn, Dr. Siriat, Peter, all very helpful and informative. And Dr. Quinn, you may be interested in, Emory also has a healthy brain study going on. So maybe there's an immediate opportunity to collaborate. But anyway,
I would love to put you in touch with Sarah Locke. That would be great.
Thank you for your contribution to our day. And to the rest of us, we're about to take a 20-minute break, and we'll reconvene at 1:30 Eastern Standard Time.
Thank you.
Great. Thank you so much.
Everybody.